Hello, I am Martin Lederman, co-founder of the organization One World, One Vision. Over a decade ago, my associate and I, while on a surgical mission to Belize, founded One World, One Vision in order to train local ophthalmologists and, by doing this, extend our reach. We were successful, and since then, our organization has gone to multiple countries and have demonstrated the success of our ideas. We added anesthesiologists and pediatric intensivists to the mission in order to train local physicians and make the surgical experience of our patients safer. Since then, we have realized that the paradigm of one patient, one student, and one surgeon, while successful, could not begin to address the need. There are tens of millions of children and adults with strabismus and amblyopia. We decided, therefore, to support and to promote a video course in strabismus and amblyopia and approached Dr. Burton Kushner to develop a curriculum and to recruit worldwide experts to give lectures. We stipulated that the course should be translated into multiple languages and to be distributed without cost around the world to eye surgeons. We are particularly grateful to our former patients and friends who have given the financial support to make our dream a reality. We are delighted that Dr. Kushner has accepted the challenge, and we hope you find the lectures both stimulating and educational, and that you share them with your colleagues and your students. And so, without further ado, I give you Dr. Burton Kushner.
Welcome, viewers, to this lecture on reoperation strategies in strabismus. It's part of the One World, One Vision comprehensive course on strabismus. I'm Burton Kushner, and although I usually just moderate these sessions, for today's lecture, I'm going to do the presentation. If you're new to this series, I thank you for tuning in. If you're a prior viewer, I hope that means that this lecture series has been useful to you, and I'm glad that you're here. Reoperation strategies in strabismus. Reoperations are certainly challenging, but they're also one of the things that make strabismus fun. There's definitely a challenge and a learning curve to this, and I would say that the more you do, the better you get. I hope that this lecture provides enough pointers that it'll just flatten that learning curve a little bit. And whenever I think of reoperations, I think of this aphorism: view every failure as a substantial discovery in a mission of trial and error. I think that that's very apt when thinking about reoperations. For this talk, we're going to discuss a little bit about advanced planning, making a surgical plan, and some intraoperative issues. Advanced planning. Well, I think it's very important to get prior records. There are some colleagues that I have who say they never need prior records. They can always do a surgical exploration and find out what they need to know. However, I think that there are a number of situations where prior records are very useful. For example, was a posterior fixation suture done in the past? Normally, when we do our surgical exploration, we don't go as far posteriorly as a posterior fixation suture was placed. So if we don't know it's there, anything we do on the tendon in the form of re-recessing or advancing anterior to that suture is not going to have the normal effect. Was an inferior oblique myectomy performed? If it was, I want to know that if I'm planning an inferior oblique transposition. Am I dealing with an overcorrection or an undercorrection? In other words, a consecutive or a residual deviation. This is going to influence whether to operate fresh muscles or reoperate previously operated muscles, and we will talk about this in detail. Was there prior vertical surgery? lateral rectus resection or a scleral buckle placed? If so, you might want to think about oblique muscle incarceration. And finally, was a superior rectus, or in fact any muscle, recessed on a hangback or suspension technique? If so, you might be dealing with non-adherence. Now, whenever I hear discussion about a reoperation when I'm on a panel or sometimes on the listserv, someone invariably brings up Cooper's dictum. What is Cooper's dictum? Well, Cooper, who published in 1961, is credited as saying, when doing a reoperation, approach it as a fresh case. In other words, don't make allowances for what was previously done. And I would say there are many exceptions. But in fact, Cooper was really quoted or misquoted out of context. He said this in the very narrow context of discussing a routine consecutive exotropia. See, when he wrote this, the common precept was that you should always advance the medial rectus muscles when dealing with a consecutive exotropia and do more surgery than was previously done, as opposed to operating the unoperated lateral rectus muscles. In fact, what Cooper actually said is that whenever an overcorrection results from extraocular muscle surgery, the case should be re-evaluated based on the diagnostic findings after the last operation. It is inadvisable to assume one should always undo prior surgery. The idea that surgery for consecutive exotropia should always undo what was previously done should be rejected. So I would say we need to amend Cooper's dictum, at least the way he's often misquoted as writing, to say that there are many exceptions. If you're dealing with restrictions, lost or slipped or weak muscles, stretched scars, distance near differences, any incompetence, or any new diagnosis. Patient now has been diagnosed with Graves' disease or had trauma, myasthenia gravis, maybe refractive error changes since their last operation. All of these things will influence our choice of what to do. So let's move on to making the actual surgical plan. And I would say decision one that you have to make, number one, is whether to operate fresh or previously operated muscles. And when thinking about this, my mind goes through what is on this flow chart. And we're going to kind of dissect this and go down each arm separately, one at a time. So we're starting with the question, fresh or previously operated muscles, and pay attention to what is highlighted in white on these next few slides. The first question you have to ask is there a limitation of rotation or no limitation of rotation? Let's go down the left side first. There's a limitation of rotation. If there's a limitation of rotation, you have to go to the previously operated muscles. Here's a patient who has a consecutive exotropia with marked limitation of adduction in her left eye. You must explore the left medial rectus muscle here. Here's a girl who also underwent bilateral medial rectus recessions, has a big left XT with an underacting medial. On your right, you'll see a dynamic MRI of her left orbit. The scan on the left of the two shows her on attempted adduction. And you can see here the absolutely typical appearance for a muscle that is either slipped in the capsule or that has a stretched scar. Posteriorly, you see this fusiform swelling of the muscle with a very thin anterior band of tissue connecting it to the globe. So knowing this, and in these situations I find imaging helpful, knowing this will help you with your surgical plan. But you certainly need to go back to the previously operated muscle. Now, I want to call your attention to something you may not have heard of. My radiologist has named this the collapsed empty channel sign. This is an MRI of a different patient, which looks very much like the one that you just saw. The difference is this eye is in relaxed neutral gaze rather than attempting adduction. Now, with the slipped muscle or stretched scar that we previously saw, you only see that fusiform swelling of the muscle on attempted adduction if it's a medial rectus muscle. This is what happens when the eye is in neutral gaze when a patient has the collapsed empty channel sign. Actually, there is no tissue connecting the muscle to the globe. This is a lost muscle. And what the radiologist I work with speculates is that when the muscle slips back in the orbit, the two opposite faces of orbital fat come together and create an interface that appears on imaging to be tissue, tendon perhaps, or an empty capsule. In fact, when you go back on these cases, this one in particular, no muscle attachment was found at surgery. Yet this looks very similar to the slipped muscle. So that is what you do if there's a limitation of rotation. What if there's no limitation? We're going to go down the right side of this flowchart now. If there's no limitation, you need to know if you're dealing with an overcorrection or an undercorrection. Let's talk about overcorrection first. And knowing this or addressing this question is one reason why I find prior records helpful. Prior records will tell you if you're dealing with an overcorrection or undercorrection. But if prior records are not available, sometimes patient or parental history, old photographs will at least tell you if the patient was perhaps esotropic when they're now exotropic, and you know you're dealing with an overcorrection. So if there's an overcorrection, I want to then know, as you see in the lower left, is there any incompetence in the form of a convergence insufficiency? So an ET that had surgery and their XT now, do they have a convergence insufficiency pattern? Or conversely, if they were exo and now they're ET, do they have a divergence insufficiency pattern? These are soft signs for muscle underaction. And if you see either of those, you need to go back on the previously operated muscles. But just to the right of that box, if there's no convergence insufficiency or divergence insufficiency, you can operate fresh muscles. Can and should. Now, what if you're dealing with an undercorrection? If you're dealing with an undercorrection, it depends if the prior surgery was close to maximum or perhaps just modest. So if it was close to maximum, patient was ET, they had medials recessed 5.5 millimeters, and they're still ET. You want to go to the fresh muscles, the unoperated lateral rectus muscles, and perhaps scale back your numbers just a bit if the prior recession was really large. On the other hand, going down the right side of this flowchart, if the prior recession was modest, ET, medials only recessed 3.5 millimeters perhaps, or 4, and there's no incompetence, you can re-recess them. Now, there's one exception to this, and I want to talk about this. This is a little bit of a digression, but it's relevant here, and that's if you have an undercorrected exotropia with lateral incompetence. First, I want to talk about the entity of exotropia with lateral incompetence de novo. Right now, I'm not talking about a reoperation. And this was described by Sally Moore, orthoptist from New York, in 1969. And I'll say this material is also going to be covered in the exotropia lecture, but I felt it's important to replicate it here. So Sally Moore observed that if an intermittent exotrope has a pattern where the deviation decreases by 10 prism diopters or more or some articles say 50% or more, in both right and left gaze, as seen here, 30 in primary, 15 in right and left gaze, these patients are very prone to overcorrection with standard surgery. Now, if you look at this pattern and you think about what can mechanistically be causing it, it must either be due to tight or overacting medial rectus muscles. I have an exo, and when I look to the side, the adducting eye has an overacting medial, so it's going to move more and decrease the exo. Or weak lateral rectus muscles. I'm exotropic, and when I look to the side, if the lateral's weak, it doesn't move as far. The other eye catches up and decreases the exotropia. Well, if this patient is starting with a de novo exotropia, it's very hard to fathom that the lateral rectus muscles are weak. So I think this pattern must be caused by overacting medials. And that explains why they're prone to overcorrection. If you have overly strong medials, you weaken the laterals, the antagonists, the overacting medials overpower those weakened lateral rectus muscles, and the patient is overcorrected. But if this same pattern occurs after prior lateral rectus recessions, same thing, 30 in primary, 15 in right and left gaze, here we know the laterals must be weak because the patients had prior lateral rectus surgery. These patients are not prone to overcorrection in primary, but they are prone to overcorrection in side gaze because the deviation is smaller, and you need to modify your surgery accordingly. With respect to surgical dose after prior surgery, at least on a previously operated muscle, and even if you're only dealing with the antagonist of previously operated muscle, formulas are questionable. I don't think that they play a role, and this is one reason I use adjustable sutures in these situations. Now, previously recessed muscles tend to shorten. They lose sarcomeres, they become stiff. So advancing them or plicating them will have a bigger effect than normal. Prior recessions, with respect to the arc of contact, you should respect the arc of contact. A small re-recession can have a big effect and can very easily cripple the muscle. And finally, previously resected muscles may have loosened, especially if they were resected years ago. So if a patient had maybe a 7 or 8 millimeter lateral rectus resection, years have gone by, that lateral rectus may have its normal elasticity, and you can resect it further if you need to, as though nothing had been done before. I've often been asked, is 1 millimeter of advancement of a recessed muscle the same as 1 millimeter of resection or plication? The answer is yes, in part, only with respect to the length tension of the muscle. So if you advance a muscle X millimeters or resect or plicate it X millimeters, you're stretching those sarcomeres the exact same amount. However, an advancement increases the arc of contact on the globe and increases the effect of the surgery, whereas a plication or resection does not. So all else being equal, an advancement is a bit more powerful than a resection or plication of the same amount. Fresh muscles, when do you modify surgery if it's a reoperation case? Well, if you're dealing with an undercorrection after a very large medial rectus recession, as I said earlier, you want to scale back the lateral rectus resection a bit, maybe a millimeter or so. When you make your surgical plan, you need to be prepared to alter it. You should expect the unexpected. Muscles may not be where they were expected to be found, and you may find evidence of totally unexpected prior surgery. When thinking of this, I like this quote from a 20th century comedian If you want to make God laugh, tell him your plan. That's definitely the case when we're talking about a surgical plan with reoperations. So with respect to reoperations, we talked about that first decision, fresh muscles or previously operated, talked about getting old records. A word about timing. In general, you want to wait about 6 to 8 weeks, or longer, of course. But there are exceptions. If on day 1 or 2 you recognize you're dealing with a slipped or lost muscle, if you have a big overcorrection after a superior oblique tuck, or if you have more than about 5 prism diopters of hypertropia after vertical rectus transposition, ideally you should go back on day 1 or 2. If you can't go back in the first week, the trade-off is you're probably better waiting till about week 6 to 8, because during weeks 2 to 3, maybe 4 postoperatively, there's much more edema, bleeding. It's just technically harder and messier surgery. Now a few words about technique, intraoperative technique. In preparation on a reoperation, I will often use steroids. If the eye is heavily scarred, only topical. I never use oral steroids in the setting. And I may use topical steroids 4 times a day for a couple weeks before in a heavily vascularized or scarred case. I'll sometimes use topical vasoconstrictors, and I generally use steroids postoperatively, also topically. Now, there's some diagnostics to perform under anesthesia, particularly in cases of reoperation. And I first want to talk about forced suctions. Usually, if an eye is restricted, let's say to adduction, eye doesn't adduct, the restriction would be out laterally. But sometimes you may clean everything up out laterally and the forced suctions are still positive. If that's the case, consider a reverse leash restriction as demonstrated in this slide on your right. So this is an eye that can't rotate to its right, that's adduction. In this hypothetical construct, the restriction laterally has been freed up, but forced suctions are still positive. And as you can see, there's a band of scar tissue running from a little anterior to the equator on the right, anteriorly in the orbit to the anterior orbital nasal wall. This is a reverse leash restriction. A nasal restriction is preventing adduction. One thing about reverse leash restrictions is they will increase in their intensity if you retropulse the globe. And that's a helpful sign to know that that's what you're dealing with. One thing to pay attention to is rotary forced suctions, particularly if there is a vertical problem or if there was prior vertical surgery. This tests for a torsional restriction. I grab the eye at either 6 and 12 o'clock or 3 and 9 o'clock. In this picture, I grab it at 6 and 12 and rotate clockwise and counterclockwise and look for where I meet resistance. If there is no torsional restriction, you will have symmetry. In this picture, you can see the eye on the top can be rotated further clockwise than it can counterclockwise in the picture at the bottom. Now that's separate from the exaggerated forced suctions, and this is something that was brought to our attention by Dave Guyton, and it's very important testing for the oblique muscles. This video you're about to see was kindly given to me by Dave Guyton with permission to use. This is the video he actually showed. This is part of the video he actually showed when he presented this for the first time at the JAAPOS meeting. Let's watch. We're going to be seeing the left eye of a patient seen from above. Horizontal forced suctions in the usual manner are normal. To test for torsional restriction, it helps to retropulse the globe, which puts the oblique muscles on stretch. Rotary forced suctions can be done in this manner to look for a torsional restriction, look for symmetry. To test for oblique muscle tightness, grab the eye at 3 and 9 o'clock. For the superior oblique, push the nasal forceps into the superior nasal quadrant and rock the eye temporally in this manner. You can see and feel the eye roll over the superior oblique tendon. For the inferior oblique, do the same in the inferior nasal quadrant. This amount of tightness is normal. We are now going to see a patient with superior oblique overaction and a pattern. When testing for the superior oblique, you can see this marked 3+ restriction as the eye rolls over the tight superior oblique. The inferior oblique is normal. Look at the eye just snap over the superior oblique. Bilateral superior oblique tenotomies were performed and the maneuver repeated. The eye now moves freely when testing for the superior oblique, indicating that the tenotomy was complete. So that's the way Dave Guyton initially described the test. Subsequently, I and others have shifted to just using one forcep in the superior or inferior nasal quadrant, and I feel the test can be done just as accurately that way with a bit less trauma. I want to talk next about the spring back balance test. This is something described by Art Jampolsky in 1978. As you see in the top of the illustration, you can grab the eye nasally and temporally and rock it back and forth. For the spring back test, grab it at one limbus and rotate it into either adduction or abduction. This is depicting rotating into abduction because the nose is at the bottom left of the photo. And then let go after you've rocked it back and forth. And see, the eye won't go all the way back to primary, but note where it ends after you let go. Then do the same thing, but letting go from the other direction. If you did abduction, do adduction, and note where the eye moves to. In the absence of a mechanical restriction, the endpoint for the spring back test will be symmetric, the same number of degrees to the abducted side as the adducted side. Now, it's important to note, and this wasn't in the original description, that this test does not assess innervational factors. So it is not necessarily the end point of your surgery. For example, sometimes hyperbole makes a point best. If I had a patient with an acute lateral rectus paralysis, let's say head injury, and if I had that patient under anesthesia on day 1, the spring back balance test would be normal. It would be symmetric because no muscle shortening has occurred in that short a period of time. There's no restriction, yet clearly that patient's eyes are not straight in the awake state. Surgery would be needed to straighten them. So the spring back test just tells you if you've eliminated the mechanical restriction. Another contribution of Art Jampolsky's is the string sign. This picture on your right shows an eye that is grabbed at the limbus with a forceps, rotated into extreme adduction, and you can see where the arrow points, that linear indentation of the globe, looking like a string indenting the globe, hence the name. That's the sign of a conjunctival restriction. If you see the string sign, you probably have to do something to either thin out the conjunctiva or perhaps to recess the conjunctiva, but at least deal with the conjunctival restriction. More on intraoperative techniques. You need to do forceductions not just at the beginning, but keep doing them as you go. Do the spring back balance test as you go, as you're eliminating connective tissue restriction and so on. And I'll often use temporary bow knots to position the muscles and then do my spring back tests and whatever. And then if I'm happy with how the testing checks out, I'll convert the bow knots into a surgeon's knot. But if not, I can easily reposition the muscle. You want to think about anterior segment ischemia, and there are several things one can do to avoid that. Craig McEwen gave us the vessel sparing technique, as seen on your left, where you can actually dissect the anterior ciliaries out of rectus muscle and spare them. It's a bit technically challenging. It's a little bit tedious, but it does work and can have a very beneficial effect. My word of advice, though, is if ever you're planning this, you should have a backup plan. Because you never know when you may inadvertently damage a vessel or when you just can't dissect the vessels out of the muscle. As seen on your right, depicts if you're planning a transposition procedure and the surgical plan would call for operating more muscles than you're comfortable with, you can do partial transpositions. This slide depicts transposing half the superior rectus and inferior rectus muscle laterally. And you can leave the other half of the muscle, particularly if there's an observed anterior ciliary vessel in the half that you leave. More recently, the Nishida procedure has been described. This is my own preferred technique if I'm worried about possible anterior segment ischemia. This involves transposing the bellies of the muscles without disinserting them at all. Another thing you can do to avoid anterior segment ischemia is possibly augment with Botox. Let's say you've done very generous surgery and you still would need to operate another muscle. You could intraoperatively inject that muscle with Botox under direct visualization and spare operating on it. And also, I'll say, although I use them infrequently, there can be a role for traction or pullover sutures, and they can be useful with stiff, inelastic muscles. This is my preferred technique. As you see in the upper left, I put two firm, non-absorbable sutures in the insertion stump. In this case, it's the inferior rectus. I pass them through the upper lid and tie them on bolsters, tying the eye up. And here's the patient the day after surgery. This muscle was done on an adjustable suture, and this has her in the desired initial overcorrected position, so I can pull the muscle forward when I adjust it. I cut out the traction sutures then, and not have to rely on an inelastic muscle taking up slack when I try to increase the recession with adjustment. A word about these cysts that can occur. They can be very, very tricky. They're inclusion cysts that typically form at the interface between a previously disinserted muscle and its new insertion. The cyst forms right at that interface, and they can often be much larger than they initially appear. Here's a cyst that doesn't look all that big, and here's that same cyst at the time of removal. All we were seeing before surgery was that lobe of the cyst that's on the left of the large cyst in the left-hand photo. It was sort of the tip of the iceberg. But the reason I'm mentioning this is shown in the diagram on the right. What happens, because the cyst forms between the interface of the recessed or resected muscle and the sclera, the cyst forms there, and in fact, the muscle often ends up not attached to the globe at all, but to the back wall of the cyst, as seen in the drawing. And to make matters more confusing, there's often a pseudotendon from the underbelly of the muscle going to the original insertion. If you're not looking for this, it's very easy to cut out the cyst and end up with a lost muscle. And I have seen this on more than one occasion. After I presented this concept with this drawing, Linda Doggy from Boston generously loaned me this slide. It's an orbital image showing exactly what was described. There's a cyst at the tip of the orange arrow, and you can see the muscle is attached to the back wall of the cyst with no connection to the globe. So that's definitely something to be careful of. A couple of technical things with a heavily scarred muscle: you pass the hook under it and it doesn't slide. What I'll do is forcibly wiggle till that tip comes out. Even if it comes out under the muscle with a lot of stuff on it, connective tissue, I'll do a sharp cut down on the tip of the hook. And to me, it's a major step in a reoperation when I've got the tip of that hook bare. You may need sharp cut down to do that. A word about slip muscles and stretch scars. They are thought by many people to be the same. I think there are some distinct differences that are worth discussing because they should be handled differently. So in both cases, you need to completely excise this abnormal tissue in front of the real muscle, either the empty capsule or the elongated or stretched scar. Now, I want to talk in this regard about the role of absorbable versus non-absorbable sutures, because you can use them in one setting and not the other. On your left is a description of the slipped muscle in the capsule. This was described by Marshall Parks, and it's thought to be due to inadequate suturing. You pass your sutures in what you think is the muscle, and you just get them in empty capsule. And then the muscle slips back without attaching to the globe in the empty capsule. So a slipped muscle will occur sooner than a stretch scar. The tissue is thinner than in a stretch scar. It's usually unilateral, unless the surgeon made the same mistake with suturing in both eyes. It's just typically in one eye. And because it's a, if you will, surgeon's error, it shouldn't recur. So if you like to use absorbable sutures, you can use them with a slip muscle. A stretch scar, on the other hand, and I think we all owe a great debt to Irene Ludwig for so carefully fleshing this out, is an intrinsic healing problem. These patients don't form the normal bond of the muscle to the sclera. So it occurs later because this connective tissue is slowly building up. The tissue is thicker than the thin, translucent, empty capsule. Since it's an intrinsic healing problem, it'll often occur bilaterally, and it'll often recur because the same problem's there. And in that situation, non-absorbable sutures are what you should use. So on your left is a picture of a slipped muscle in the capsule, and you see the thin capsule held up by the sutures, and the white arrow depicts the anterior edge of the muscle slipped in the capsule. On your right is a stretch scar. The tissue looks thicker than the empty capsule, and that arrow points to the interface between the elongated tendon or scar and the actual muscle. And that can be sometimes difficult to discern. I find it most helpful to slide a hook back and forth over the top of the muscle, and you can actually feel a bump when you're getting to actual muscle. So the girl I showed earlier, the one I showed the orbital MRI of, underwent surgery, and I excised 14 millimeters of scar before I got to true muscle. As you can see on your left, it was all connective tissue. There was no muscle in it. And here she is shortly after surgery, showing good alignment and essentially full adduction. Now, what I just showed you, the empty capsule or the stretch scar, is different than the type of pseudotendon that was described a long time ago by Ken Swan. When a muscle is recessed and it bonds normally, it's normal for a connective tissue pseudotendon to grow from the front of that recessed muscle to the original insertion. It doesn't always happen, but it often happens. This is a cross-section showing the recessed tendon of the muscle itself on the far right, and anterior to that, to the left of that, anteriorly from the surgeon's viewpoint, is a pseudotendon, and it's thick at the start, and then there's a thin extension of that continues all the way to the old insertion. It's important to know that this occurs because it can very easily be mistaken for the muscle itself. On more than one occasion, I have hooked it, sutured it, gone so far as to disinsert it, and then realized, this is a little bit thin. Pass a hook further back and get the muscle itself. And this tissue is of no use. You can just cut it away, excise it, and dispose of it. So this is different from the kind of pseudotendon that occurs with non-adherence. And this is just another view showing the reflected pseudotendon in the clamp that's in the middle. Whenever you're dealing with a vertical with limitation of rotation, consider oblique muscle incarceration. A superior oblique tendon can get incarcerated after superior rectus surgery, typically resection or advancement, superior oblique surgery, and after a scleral buckle. It's characterized by a restrictive hypertropia with an encyclotropia. And the slide on your right shows this. You'll see the superior rectus outlined with black dashes, and the superior oblique tendon outlined with white dots is scarred into the insertion of the superior rectus. That's the superior oblique incarceration. You can also get inferior oblique incarceration, and I've seen this typically after lateral rectus resection or after a scleral buckling procedure. This is an artist's drawing of the inferior oblique, in effect being tucked by a scleral buckle. When the surgeon hooked the inferior rectus to place the encircling band, he inadvertently hooked the inferior oblique. The inferior oblique was then tucked by the circling band that went around the globe. And this is characterized by a restrictive hypotropia with an excyclotropia. When dealing with strabismus after a scleral buckle, I personally rarely need to remove the buckle. One thing you can do if you have concern is you could just approach the muscle posterior to the buckle, put sutures in there, resect it, advance it, recess it, whatever you want to do, and leave the muscle that's scarred to the buckle alone, the part of the muscle that's scarred to the buckle alone. If you use adjustable sutures, I'm often asked, can you use absorbable sutures, or do you have to use non-absorbable sutures? I think that if you're doing a case after a buckle, if your dissection leaves the scleral buckle encased in that fibrous capsule that forms around it, you can use absorbable sutures. A muscle will bond on a suspension technique to that fibrous capsule. But if your dissection resulted in the buccal material being bared, you cannot rely, you should not expect the muscle to adhere to bare silicone. So you should not use absorbable sutures. So in summary, we've talked about when to operate fresh muscles versus previously operated muscles, the importance of a limitation of rotation, overcorrection versus undercorrection, what timing should we employ, and some technical issues. So I'd close with saying you probably should follow Cooper's dictum, except when you shouldn't. I want to thank you for your attention. I hope this was helpful to you, and my wish is that all the roads you travel lead to orthophoria.
In bringing you this video course, there are many thank yous. Thank you for viewing the video course on strabismus. We hope you found it stimulating and educational, and that you share its insight with others. We at One World, One Vision extend our heartfelt thanks to the lecturers who shared their years of study to make the video course worthwhile. And of course, to Burton Kushner for taking on the burden, happily we hope, of development and moderating. We also thank the board of directors for their continued guidance. We thank our donors for their financial support that made this video course possible. An enormous thank you to the video team of Sweet Sadie for their extraordinary efforts to make the course, both visually and auditorially, extraordinary, and for their technical guidance of the lecturers. Thank you, Rachel, Tim, Eddie, and Bill. If you are interested in learning more about what we do, go to our website, www.oneworldonevision.org. And finally, if you have comments or thoughts or ideas, you can email me at owov2020@gmail.com. Goodbye.